Hello, my name is Joseph Sassine. I'm Professor and Associate Dean for Clinical Affairs, and this presentation is Comprehensive Statin Initiation Education and Certification for the Colorado Pharmacists. This program is intended to train pharmacists on how to use a statewide protocol for initiating statin therapy. The objectives of this training program are to first describe the Colorado State Board of Pharmacy statewide protocol for statin therapy, which is an initiation protocol. It's also important to be able to identify the 4 statin benefit groups that are identified in our 2018 cholesterol guideline recommendations, and importantly, explain the risks and benefits of statin therapy, including the definition of statin intolerance. I have no disclosures. First, let's start off, why do we have a statewide protocol and why do we actually care? The first is what we know about atherosclerotic cardiovascular disease. Despite significant intervention, it still remains the leading cause of disease worldwide, affecting half of our adults in the United States, and it remains the #1 killer and cause of mortality in the United States. Unfortunately, our projections for what's going to happen out to the year 2060 come from the 2020 census, and it indicates that we're going to still have an increase in the overall burden of ASCVD risk factors, things like diabetes, hypertension, dyslipidemia, and obesity, which highlight that treating patients and reducing risk of cardiovascular disease is going to continue for the next 4 decades. Specifically, when we focus on hypercholesterolemia, we know there's different types of lipoproteins. There's total cholesterol, HDL cholesterol, triglycerides, and also, most importantly, LDL cholesterol. LDL cholesterol is our primary atherogenic lipoprotein, which is targeted in the United States. In other countries, they use apolipoprotein B or sometimes even non-HDL, but all 3 of these, LDL cholesterol, apolipoprotein B, and non-HDL cholesterol, are all atherogenic. In the United States, this is the focus of our targeted interventions to reduce cardiovascular risk and treat hypercholesterolemia. We know that statin therapy is first line. It reduces LDL cholesterol, and it's also proven to reduce the risk of ASCVD events in patients who have risk for ASCVD. ASCVD standing for atherosclerotic cardiovascular disease, which is the end consequence of cardiovascular risk factors, especially high LDL cholesterol. We don't have a perfect situation in the United States. We know that many patients who are statin eligible are not on statin therapy, and this is from numerous data points from different studies. The first study I have on here was published in 2020. It evaluates statin use in the United States amongst the highest risk patients, which are those with already established ASCVD. This evaluated over 600,000 of them, and it showed that almost half were on no statin therapy at all, which is disappointing since we know the burden of proof is heavy, showing that statin therapy reduces cardiovascular events and prolongs mortality in ASCVD patients. Of those who were on a form of therapy, only 22.5% were on high-intensity statin therapy, which is recommended, and 27.6% were on some other form of statin. This has been replicated in other databases. The largest that I've seen is the Pinnacle Registry, which looks at cardiology practices across the United States, and they identified 2.5+ million Americans who had ASCVD from these cardiology practices. And you can see that no lipid-lowering medication was predominant. Very similar statistics. This comes from data from 2019, showing over half were on no lipid-lowering therapy. And of those who are on statin therapy, I assume that the same kind of prevalence of distribution of high intensity versus moderate intensity or lower intensity is what was seen in the Nelson study. But here they looked at the LDL values that were achieved, and they had LDLs available in over 1 million of these patients. They showed that only 31.9% had LDL values of less than 70, which has been the traditional standard. Our newer standards to treat even more aggressively for many of these patients, with about 70% having values above or equal to 70 milligrams per deciliter. So showing that even when we use statin therapy, there's a gap in optimal treatment. Here in the state of Colorado, we have a statewide protocol to initiate statin therapy. It's found in Appendix E at the web link listed at the bottom of the slide. This statewide protocol authorized qualified Colorado licensed pharmacists to provide pertinent assessment of patients with or at high risk for cardiovascular events, and to initiate via prescribing statin therapy and it's for the purpose of reducing the risk of new or recurrent cardiovascular events according to and in compliance with all applicable state and federal laws and rules. So this is a powerful tool that we have as Colorado pharmacists. Pharmacists may prescribe and then dispense FDA-approved medications to eligible patients according to this protocol. And according to this protocol, it follows indications and contraindications that are recommended based on our best practices, which are our current guidelines from the American Heart Association in collaboration with the American College of Cardiology, or any subsequent updated published guidelines, which is recognized as the national standard of care in the United States. This statewide protocol identifies qualified pharmacists as those who are licensed, engaged in practice with a PharmD degree, or 5 years of experience as a licensed pharmacist. They also must uphold and have active professional liability insurance, complete an ACP accredited training program pursuant to the protocol, which is this protocol, this training program, and they must follow all board rules and regulations for statewide protocols that are found in section 17.00.00. Who are the patients that are targeted? Well, its eligible patients are patients from all the 4 identified statin benefit groups, and in particular, the 4th statin benefit group, meaning primary prevention without diabetes. They must have a 10-year ASC risk score of 20% or higher, all of which will be covered later in this educational program. There's other requirements for record keeping, contraindications, monitoring, counseling, and also for referrals. Let's get deep into some of these regulations within the statin protocol. First, about record keeping and records. And this is pursuant to Pharmacy Board Rule 17.00.50. And that states that a process shall be in place for the pharmacist engaging in this protocol to communicate with the patient's primary care provider and document any changes to the patient's medical record, which would be using and initiating statin therapy. If the patient does not have a primary care provider or is unable to provide the contact information for their provider, the pharmacist shall provide the patient with a written record of drugs or devices furnished and laboratory tests ordered and any other tests that are also available. So this is how we implement the protocol if no provider is available, to actually document what was done and the tests that were collected. Some pharmacists may actually collect the lipid panel and sometimes even LFT monitoring. They would need to provide this as a written record to the patient in the absence of contacting the provider. The pharmacist should also comply with any pharmacy board rules, which are cited here in section 17 with respect to the maintenance of proper records. The statin therapy protocol allows pharmacists to assess patients with or at high risk for a cardiovascular event or the development of atherosclerotic cardiovascular disease who are not on current therapy, but in whom statin therapy is classified according to our guidelines from the AHA and ACC collaboratively as a class 1 recommendation, which means high confidence by the experts, being AHA and ACC, that benefit outweighs risk. Let's talk about how statins work. It's important to know the pharmacology, and statins are HMG-CoA reductase inhibitors. We see on the left here that acetyl-CoA gets converted into HMG-CoA and then enzymatically gets converted to mevalonate, and mevalonate turns into cholesterol. The way that statins simply work is they competitively inhibit the HMG-CoA reductase enzyme. And by doing this, there's decreased cholesterol production. But we also get an increase in LDL clearance receptors, LDL receptors. When your body notices that it's not producing as much cholesterol, the clearance receptors pull LDL particles out of the circulation and pull it into the liver to be broken down for physiologic purposes. Since your body is engineered to use a little bit of cholesterol, it knows to turn on this process to scavenger up what is available. Overall, this is good for cardiovascular health because it pulls LDL out of the circulation where it has no physiologic purpose and just causes harm by propagating atherosclerotic lesions and plaque within arteries. Statins overall are first line for most patients with hypercholesterolemia since they are proven to reduce LDL cholesterol, but most importantly, they're proven based on multiple studies to reduce morbidity and mortality and recurrent cardiovascular events in high-risk patients. They're very effective in lowering LDL cholesterol. It's a dose-dependent manner, and it varies depending on the statin. There's also perhaps some other benefits aside from LDL cholesterol in stabilizing atherosclerotic plaques, maybe decreasing inflammation and decreasing progression of atherosclerotic lesions, but the primary effect really is LDL lowering. These drugs do have side effects, but overall, considering how many people are on them, they are considered collectively well tolerated. To summarize all the evidence that we have with statin therapy, the cholesterol treatment trialists have put together this classic landmark analysis, which shows the relationship in clinical trials between the reduction in LDL cholesterol and the proportionate reduction in major vascular event rates. This analysis from 2005 can be updated. It shows the same exact relationship, but this looked at 14 statin trials versus placebo. And each box within the figure represents an individual trial, one of the 14, and the size of the box represents how many people were in the trial. So what's plotted here on the x-axis is the reduction in LDL cholesterol achieved in the clinical trial, plotted against the proportionate reduction in vascular events. And we see that the higher or the more LDL is reduced, the more event rates we achieve. And we get this predictable relationship. That regression line has been seen for one analysis versus another. Even newer LDL lowering agents that evaluate LDL lowering therapy versus another intervention or placebo seem to fall in this regression line. Basically, the more you reduce LDL, the more event reduction you get. And we can also see that for every millimole reduction in LDL cholesterol, we get about a 22% reduction in vascular events. 1 millimole is about 39 milligrams per deciliter, which is the power of what a statin can provide. The 4 statin benefit groups have not changed since 2013. The first statin benefit group are patients with established clinical ASCVD. We call these secondary prevention patients. And the other 3 groups are primary prevention patients, meaning no history of ASCVD, but have either very high LDL cholesterol values at baseline, which means 190 milligrams per deciliter or higher, or diabetes between the age of 40 and 75, or age 40 to 75 and an increased risk of ASCVD based on the pooled cohort equations. We'll go through each of these 4 statin benefit groups. This is the algorithm that you'll see in the guidelines for each of the statin benefit groups, modified to some extent. This highlights what first-line therapy is. So we see secondary prevention on the left and then the 3 primary prevention populations on the right. And under each circumstance, when therapy is recommended, either moderate or high-intensity statin therapy is recommended. And we also see here that the green recommendations are the class 1 recommendations from the guidelines, which are the ones in the protocol that we can implement according to the statewide protocol, the class 1 recommendations from the AHA-ACC group. Let's talk about the first statin benefit group. These are people with who we call secondary prevention patients, or those with clinical ASCVD. Now, these are patients who have disease that stem from atherosclerotic origins and is confirmed by the pharmacist by either patient report, medical records, or prescription history. The kind of patient with clinical ASCVD probably is going to be on beta blocker therapy, an antiplatelet drug, most likely an ACE inhibitor or an ARB2. But these include patients who have a prior history of an acute heart attack, which is a myocardial infarction. They may have a history of an acute coronary syndrome, which sent them to the hospital. They could have a history of stable or unstable angina. And both of those latter 2 collectively are referred to sometimes as NSTEMIs or STEMIs, which is non-ST segment elevation MI or ST segment elevation MI. It could also include a patient with coronary arterial revascularization procedures, such as a patient who's had a coronary artery bypass graft surgery, which is CABG surgery, or some kind of cardiac stenting. It could also be a patient who has a history of an ischemic stroke, but not from embolic origin. It's a non-cardioembolic origin. Cardioembolic strokes are from atrial fibrillation, so this would not be those types. Or it can also be a patient with a transient ischemic attack, an aortic aneurysm history, or peripheral arterial disease, especially symptomatic peripheral arterial disease that we call PAD. So these are all the clinical forms of ASCVD, which if they are identified in a patient, they fit the statin benefit group, they are considered clinical ASCVD patients or secondary prevention patients. The treatment algorithm in the 2018 guidelines state that when you identify a patient who's secondary prevention, to assess whether they're very high risk or not. Very high risk, if you look to the tables to the right, include patients who have a history of multiple major ASCVD events, things like the acute coronary syndrome, myocardial infarction, ischemic stroke, or symptomatic PAD. Or they can have just one of those and multiple high-risk conditions. All the things that are listed at below here. Things like advanced age, diabetes, hypertension, smoking, congestive heart failure, and a few other are included in that definition. Now, it might not matter because if you go to the algorithm on the left, if somebody is very high risk, then you use high-intensity statin therapy. But even if they're not, you should use high-intensity statin therapy for people 75 and younger, and it's an option for people who are above the age of 75. So statin therapy is absolutely recommended in this population. The only deviation from high-intensity statin therapy is if you have a very elderly patient, perhaps in their not very high risk, you might be able to use a moderate intensity statin. But when you look at the working definition of what very high risk is, 97% of our patients, based on what we know in the literature, will fit the definition of very high risk. So most people, it's going to be high-intensity statin therapy, which is recommended if they have clinical ASCVD. The second statin benefit group are patients who have baseline LDL cholesterol values of 190 or higher. This is not normal. These people are at high risk for premature ASCVD. Many of them will have a genetic abnormality called familial hypercholesterolemia. Some of them do not. They just have very high LDL cholesterol values. And the higher LDL, the more plaque that develops in your coronaries, cerebral, and peripheral arteries, which can cause clinical disease. Now, baseline here refers to before any lipid-lowering therapy, not just statin therapy. And this applies to patients aged 20 to 75 years of age. There are some recommendations for people under the age of 20. These are pediatric patients who probably have familial hypercholesterolemia. That's beyond the scope of this statewide protocol. The statewide protocol is really for patients at least age 20. And what's recommended here for first-line therapy with a green class 1 recommendation is high-intensity statin therapy. Our third statin benefit group are patients who often fall in the cracks. And these are patients who are primary prevention, who also have diabetes, either type 1 or type 2, between the ages of 40 and 75 years of age. Now, this type 1 or type 2 diabetes co-indication or comorbidity can be determined by patient report, medical records, or prescription history. And obviously, if you see somebody who's on insulin therapy, they have diabetes. Where now if we see that they're on an SGLT2 inhibitor, that may be an indicator that they have cardiovascular disease versus diabetes, or they may have both. So use your judgment as a pharmacist. Now, these patients don't fit into the previous group. They have LDL values of less than 190 at baseline, and that's before lipid-lowering therapy. And the recommendation here in these patients, these primary prevention diabetes patients age 40 to 75 with LDLs of less than 190, is to use either moderate intensity statin therapy or high intensity statin therapy. Moderate intensity statin therapy, according to 2018 guidelines, is the class 1 recommendation, or high intensity statin therapy is a class 2A recommendation. Now, when would you go to high intensity statin therapy? We have further recommendations from the ACC group that states that high intensity statin therapy should be the starting therapy in this population if your diabetes patient has a 10-year ASCVD risk score of 7.5% up to 19.9. If it's 20% or greater, you definitely use it. Also, if they have diabetes-specific risk-enhancing factors or subclinical atherosclerosis. I do want to spend just a little bit more time on this aspect because this recommendation to start high-intensity statin therapy with any of the three being the risk score of 7.5% or higher, diabetes-specific risk-enhancing factors, which is a long duration of diabetes for either type 1 or type 2 according to the years that are listed on this slide, the presence of albuminuria, retinopathy, neuropathy, or an ankle brachial index of less than 0.9. And lastly, subclinical atherosclerosis comes from the 2022 ACC Expert Consensus Decision Pathway recommendations, which I will discuss a little bit further. So this is a little bit more clarity in when to use high-intensity statin therapy in the 2022 ACC Expert Consensus recommendations versus the 2018 recommendations from the guideline group. The last statin benefit group, or the fourth statin benefit group, are your primary prevention patients between the ages of 40 and 75 years of age who have elevated ASCVD risk. And how do we determine elevated ASCVD risk? Well, we calculate using what's called the pooled cohort equation, the 10-year risk of ASCVD. And when you use this pooled cohort equation, you can actually access it from the American College of Cardiology Risk Calculator. It's available with the web link that's listed in this slide. You can download it onto your phone, whether it's an iPhone or an Android, and have that tool available. This will, if you put in specific characteristics, things like age, somebody's total cholesterol, HDL value, their smoking status, their systolic blood pressure, and whether they're on antihypertensive therapy or not, and whether they have diabetes, you put in all those variables. They're also their race is also included in there too. You will get a 10-year risk score, and that's a 10-year risk score for hard ASCVD. Now, the algorithm for this population is listed below. The thing that is important to highlight, only primary prevention patients with a 10-year risk score of 20% or higher are included in this protocol. You can see that patients with 7.5 to 19.9% risk may have a green moderate intensity recommendation for initiating statin therapy, but it does require further risk estimation and availability of risk-enhancing factors. Some of these may not be known by the patient or well documented in medical literature, or medical records, I should say. So because of that, the protocol is written to address in this population only patients who have a 10-year risk score of 20% or greater. Perhaps in the future this may change, but that is the current approved statewide protocol to only target in this primary prevention group those with a 20-year risk score of 20% or higher, because there's high confidence that the data that are available by the pharmacist using this protocol is appropriately identifying a patient as high risk for ASCVD and statin eligible. In our statewide protocol, there's also some patients who this protocol does not apply to. So these are the ineligibility criteria. The first would be a patient who has a history of serious statin-associated side effects. This would include a serum creatine kinase elevation, which is greater than 3 times upper limit of normal. If that's associated with statin therapy in the past, that could be implying that the patient has a history of statin myopathy, and that's a population that is not included in this protocol. It could be somebody who's experienced rhabdomyolysis in the past while on statin therapy, or somebody who had hepatotoxicity, which is pretty rare. And this is defined as hepatic transaminase elevations 3 times upper limit normal or greater during prior treatment with statin therapy. The second ineligibility criteria are patients with active liver disease, and this is defined by medical history or by their hepatic transaminases being greater than 3 times upper limit normal. This definitely implies that somebody's having active liver disease, and that's a contraindication to statin therapy. Also excluded in number 3 are women who are pregnant or are of childbearing age and who are not using highly effective forms of contraception. Currently, statins are still listed as incompatible with pregnancy, though that may be changing. And until that changes, our statewide protocol still excludes that population. Patients who have end-stage renal disease or who are undergoing hemodialysis or peritoneal dialysis are excluded from this protocol. I define end-stage renal disease as an eGFR of less than 15, which is stage 5 CKD. And lastly, patients who have severe hypertriglyceridemia. And if their fasting triglycerides are 1,000 or higher, they're at risk for pancreatitis, and a statin is not going to do it. They should be referred for other therapy. The protocol recommends either high-intensity statin therapy or moderate-intensity statin therapy, depending on the patient presentation. There are only 2 statins which are considered high-intensity, the first being atorvastatin 40 or 80 milligrams daily, and the second being rosuvastatin 20 or 40 milligrams daily. Every other statin, or these 2 statins at their lower recommended starting dose, initial starting dose, provide at least moderate intensity lowering. High intensity is a dose of a statin that on average provides at least a 50% lowering in LDL cholesterol, where moderate intensity is between typically 30 and 49%. It's also important to note that patients who have a creatinine clearance of less than 30 milligrams per deciliter, please do not use rosuvastatin 20 or 40 milligrams daily. The dose of that particular statin should be limited to either 5 to 10 milligrams daily or use atorvastatin, which does not have the renal dosing issues that rosuvastatin does. Our statewide protocol also talks about medication options for the patient. And this includes that the pharmacist must screen the patient for potential statin drug-drug interactions, because this is important. There's many of them available. It may actually result in picking a certain statin or avoiding some other therapy. And this is for patients with known medications available to the pharmacist. The pharmacist should do a very diligent and thorough medication reconciliation before prescribing statin therapy under this protocol. If an interaction is identified or is potential, appropriate selection of a safe statin regimen and counseling of the patient should be performed to mitigate this risk. I can't emphasize enough that this is a very important step, something that we as pharmacists should be able to do very well. I argue that we would do them better than any other healthcare professional because of our specific training. There are many ways to manage and mitigate risk of a drug-drug interaction with a statin, whether it be, as I said, picking a different statin, perhaps even a different dose, or modifying the causative drug for the drug interaction. We have several different statins available. There are 7 on the market, and 6 of the 7 are available as generic products. Listed in this table is each statin based successively on how they were approved by the FDA. So lovastatin was the first statin, and pitavastatin was the last statin approved. We have first information about distribution, which is defined by the lipophilicity of the drug, and that's determined by the log P of the individual statin. Any log P value which is 1.0 or higher implies that the drug is lipophilic, meaning that it penetrates lipid tissue more than water tissue. We see that lovastatin and simvastatin are very lipophilic, as is atorvastatin. And there really are only 2 statins, pravastatin and rosuvastatin, which are considered not lipophilic but hydrophilic. So they're non-lipophilic or, oppositely, hydrophilic. They penetrate water tissue more than fat tissue. There is a theory that the hydrophilic statins may result in less or fewer statin-associated muscle symptoms than the lipophilic agents. This may or may not be true, but when you have to actually consider selection of a specific statin in a patient who maybe in the past just had muscle symptoms from a statin, maybe switching to a hydrophilic option may be prudent. We also have information on metabolism, which is where we get some of the drug interaction potential. We see that every statin except for pravastatin requires metabolism through the CYP system. Most of the CYP enzymes are 3A4, like we see with lovastatin and simvastatin, and to a smaller extent atorvastatin. But some of the other statins also go through the CYP2C9. So if you have an interaction that affects this 3A4 or the 2C9, we may have to investigate what the appropriate dose is to use or what an alternative statin to avoid a drug-drug interaction would be. Lastly, we have excretion information here. We have renal excretion, and this is the percent of the drug which is eliminated unchanged in the body. We see that atorvastatin has the least amount of renal excretion, so that's why it's the safest in patients with kidney dysfunction, where other drugs, if anything, that probably has renal elimination of 10% or higher. We have to think about it in patients with severe kidney dysfunction, and that's why we have some dose restrictions with rosuvastatin. Its renal excretion is 10%, but in patients with creatinine clearances of 30 or worse, we should avoid using 20 or 40 milligrams of that particular statin. You can look to the product labeling for some other guidance for the other listed statins. Lastly, we have half-life. There are 3 statins which have a long half-life, that being atorvastatin, rosuvastatin, and pitavastatin. That means that these can be dosed anytime during the day, whether it be in the morning, afternoon, or night. But the short half-life statins, if you're using a regular immediate release product, should be given at bedtime or at late, the earliest would be dinner time in patients who have an average sleep-wake cycle where they go to bed around 10 to 12 p.m. So that the concentration of the statin can be highest when your body makes the most HMG-CoA reductase, which so happens to be overnight. So short half-life statins need to be dosed near the evening, or long half-life statins, it really doesn't matter. And that is to maximize the LDL lowering ability based on the mechanism of action. There is monitoring that's required for statin therapy. The first is the most important one, the fasting lipid panel. Now, some people think that being on a statin is good enough, and that is not true. You need to be on a statin. You need to assure that you're getting a typical response in LDL lowering and achieving the thresholds that are recommended by our national experts. Now, the statin protocol is for initiating statin therapy to provide ongoing LDL lowering monitoring and titration that would require a collaborative practice agreement or a collaborative drug therapy management protocol. But knowing that every 3 to 12 months a lipid panel should be measured is important. Now, we want to actually, in specifically our guideline recommendations, to get a fasting lipid panel at baseline to determine what your your patient's starting point is and whether they're eligible for a statin, and then doing it 4 to 12 weeks after initiating therapy. Every 3 to 12 months comes when patients are on chronic ongoing maintenance therapy to assess their LDL lowering capability, whether they're at the intended goal, and also to assess for adherence. Now, the guidelines do allow for a non-fasting panel to be collected for baseline LDL cholesterol, but please recognize that if you have a non-fasting lipid panel and it reports out or calculates out LDL cholesterol, it often is falsely low. And that's because your triglycerides are high and the calculated LDL value goes down. But for baseline LDL, that's what's recommended. But for follow-up monitoring, what is always recommended there forward is a fasting lipid panel. So I guess if the LDL is falsely low and it's your baseline value and they still meet eligibility criteria, you know their LDL is higher at baseline, you know it's probably a calculated risk there. But the ongoing monitoring is a fasting lipid panel to make sure that that LDL is accurately calculated. There are point of care tests, and these are acceptable. They can be done in pharmacies to actually collect that information at baseline. And baseline labs can also be collected from the primary care provider. And if it's within 3 months of statin initiation, you can go with that. Otherwise, within this protocol, you would have to recollect those baseline labs if it's beyond the 3 months. Also, it's important to know what the recommendations are for hepatic transaminases. Now, overall, the frequency is really, the baseline is required. You need to see what somebody's baseline liver function is to see if they have an exclusion, whether they should be out of this protocol or not, because that would be a contraindication to statin therapy if there's active liver disease. But as far as what's required thereafter, routine monitoring is not needed. Routine monitoring went away over 10 years ago. The only time that we actually want to recommend monitoring of liver function tests, which are hepatic transaminases after starting statin therapy, are in patients who present with symptoms that are suspicious of liver disease. These patients should be referred for medical evaluation, and that's probably a patient who has severe belly, severe stomach, abdominal pain, or if they are yellow, indicating that they may have jaundice. Now, I do want to go back to the baseline testing of hepatic function. This can be ordered by a pharmacist, but it's also acceptable and that it be received in written documentation from the PCP within 3 months of statin therapy. So the same 3-month time frame that we have with the baseline LDL cholesterol applies to the baseline hepatic transaminase panel too. Renal function test is also a required monitoring parameter. The frequency is baseline and yearly thereafter, just to determine whether patients have chronic kidney disease and may need an adjustment in their statin therapy, depending on which one they're in. Now, as far as the guideline recommendations for renal function, it's not in the national guidelines, but it is recommended within this statewide protocol. Overall yearly monitoring, because of dose adjustments, is prudent. And again, this will be ordered by pharmacists or it could be communicated to the patient and when you do the follow-up and the pass-off to the primary care provider. That's what's also recommended once a year is renal function testing thereafter. Going further in the statewide protocol, there is detail about counseling. This is a minimum for patient counseling about statin therapy. First, it's important for the pharmacist to discuss with the patient the importance of medication adherence. If patients don't take their statin, they're not going to get the reductions in cardiovascular events. So that's a very important message to share with our patients, something that we should do within our domain. And this is in relation to the efficacy of the statin therapy and the risk reduction event. What to do for a missed dose. We don't typically have patients double up on their next dose. If it's beyond, in my mind, up to 12 hours, they can, if it's within 12 hours, they can take that dose. But if it's beyond 12 hours, just forget about it and restart the next day and with a normal dose. Also covering the importance of lifestyle changes. When patients start lipid-lowering therapy, they still should decrease their saturated fat intake, decrease their refined sugar intake, avoid trans fats, and also engage, if possible, and cleared by their provider in a regular aerobic activity to reduce both their lipids and their cardiovascular risk. We should also cover the proper use of medication, how to take it with a full glass of water at or near bedtime. If it's a short half-life statin, how to store it, which is standard storage, the dosing, the scheduling, and any potential common or serious side effects, and importantly, not to overreact to the fear of side effects or the noticing of muscle aches and pains, to really come for advice from the pharmacist or their medical provider on how to manage that. Also important to cover signs and symptoms of not only muscle symptoms, but liver dysfunction, even though it's extremely rare, and educate patients that these are not common, but if they present themselves, then to seek advice from a healthcare professional. Also covering some potential food and medication interactions. Now, most of our drug-drug interactions occur with lovastatin and simvastatin, and lovastatin is the one where you need to take it with food. Lovastatin and simvastatin is also the one if people ingest a lot of grapefruit juice that they can inhibit some of their 3A4. So those need to also be covered too, not just exclusively with lovastatin and simvastatin, but with all of our statins. And using our judgment prudently is what should occur with our patient counseling encounters. And lastly, patients should know to follow up with their primary care provider. And we're going to follow actually the documentation and the referral to the provider that's stated in this statewide protocol, but inform the patient of that referral also, and that they would need their lipid test done at least yearly, 3 to 12 months on an ongoing basis. But importantly, after starting that statin therapy, within 12 weeks, they really should have a repeat lipid panel, fasting lipid panel, to assure that their LDL is sufficiently lowered. Now, what do I mean by LDL sufficiently lowered? Well, this is really according to the 2022 guidance, which comes from the American College of Cardiology. This is the expert consensus decision pathway, and this is pretty new. What does the decision pathway say? It says initiate first therapy according to the 2018 AHA-ACC multi-sided cholesterol guidelines. So that's what our statewide protocol does. It follows for the 4 statin benefit groups, and in the 4th group, it has to have a risk. Your patient has to have a 10-year risk of 20% or higher to be in this protocol, but the other 3 groups are, if they're in that group, then they are eligible for this protocol, is to start therapy that way. But importantly, we need to check LDL cholesterol 4 to 12 weeks after starting therapy to make sure that the percent reduction, which is predicted based on the statin used, is achieved, and that the LDL threshold is achieved. This is pretty new. Every single statin benefit group now has a threshold. It's either 55, 70, or 100, depending on their risk. And if you don't achieve that threshold, you maximize the dose of your statin. You should also, if you're not at your LDL threshold or reduction percentage, you should evaluate and optimize lifestyle modifications, reinforce adherence, and control other risk factors, and reevaluate LDL cholesterol. If your patient's on maximally tolerated statin therapy and they're still not at both their percent reduction, which is predicted based on the statin, and the LDL threshold, that's when a non-statin agent should be recommended, with a repeat lipid panel in 4 to 12 weeks to recheck that LDL cholesterol. And even when you get your LDL controlled, if you look to the right of this figure, they refer clinicians to a 2021 expert consensus decision pathway by ACC about high triglycerides. So I share this with you. This is beyond the protocol that we have in the state of Colorado for pharmacists to prescribe statin therapy is the top dark green box. It's starting initial therapy, but I think it's prudent to know what steps should occur thereafter for your patients so you can fully provide the most cardiovascular risk reduction possible and empower them to take control of their health. If you're interested in what the percent reduction from baseline is in the LDL thresholds, it's all listed on this particular table. This is a summary of those 2022 expert consensus recommendations. All 4 statin benefit groups are in their own individual row here, and there's some subtypes within each particular group. But you can see that the percent reduction from baseline is 50% or more for any time that a high-intensity statin therapy is recommended. And whenever a moderate-intensity statin therapy is recommended, it's 30 to 49%. But more importantly, probably is the LDL threshold. And if you take a look at the secondary prevention population who are very high risk, what's recommended now is an LDL threshold of less than 55. Now, call that your target LDL, your goal LDL, I don't care what you call it, but it's the value at which you should achieve. And that is lower than what has been recommended in the past. So in your counseling of your patient, highlighting, perhaps sharing with them what the LDL target or threshold value should be is important. often we find that people are not treated sufficiently. And if you're not treated sufficiently, you're not going to get the maximum cardiovascular risk reduction. Coming full circle, why is that important? Well, cardiovascular disease still is the #1 cause of death in the United States. So if we want to actually improve that, we need to fully inform patients and work to be a bit more aggressive with lipid management. Statin therapy, we know, has some limitations. We got the list of high intensity and moderate intensity statins on the left, and there's a lot of options for us available. But what limits patients from staying on their statin, getting their statin, or being adherent with their statin? Well, it could be that patients just are patients and they have non-adherence and lack of persistence. Sometimes they start a therapy and they stop refilling it. They think it's an antibiotic, or once they get their first LDL measurement back and it's good, they actually think, oh, I'm great and I can stop my drug. So that sometimes happens. Sometimes people fall a little bit short too. They could be prescribed atorvastatin 80 milligrams daily and maybe they only get a 30 or 40% reduction. They get less than what's predicted, even with adherence, and that sometimes happens. And it doesn't mean that they're going to be fully protected or have maximal cardiovascular risk reduction. It means that they might need a non-statin option as an add-on. But probably more important or more common is side effects. We have statin-associated side effects, which include statin-associated muscle symptoms, which either are real or perceived by your patient. Let's talk a little bit about statin muscle symptoms and the term statin intolerance. So statin intolerance has been used left and right in the medical literature with multiple definitions, and these definitions haven't always been the same. In 2022, the National Lipid Association published a new definition of statin intolerance. I was really happy that I was the president of the NLA during this time, and I was one of the authors along with Mary Catherine Sheely, who is a PharmD from Georgia. And she led our team to develop this definition of statin intolerance. And it's defined as one or more side effects or adverse effects that are associated with statin therapy. But the key is that these adverse effects either go away or improve when you reduce the dose or stop the statin. So confirming that it is related to the statin. Now, also it's associated with an inability to tolerate that dose that's necessary to achieve the therapeutic objective, which is LDL lowering, whether it's percent or threshold or both of those. Now, to classify or label somebody as statin intolerant, the patient really needs to be exposed to at least 2 statins. 2 should be tried, and 1 should be at the lowest approved daily dosage. So somebody who fails atorvastatin 80 and rosuvastatin 40 don't meet this definition because both of those are the highest doses. One of them should be the lowest approved starting dose. Now, patients can have complete statin intolerance, which means they meet this definition on the left, but they can't tolerate any dose of a statin. But you may have somebody who has partially statin intolerant. They can tolerate a dose of a statin, a smaller dose, either low intensity or lower, but it doesn't achieve their therapeutic objectives. So there still is a need to further treat them. This may be off-label dosing where patients only tolerate once or twice a week rosuvastatin or atorvastatin. If they meet this definition on the left, they may be somebody who's partially statin intolerant. These are patients that are beyond this protocol, but it's important to know that this is a potential outcome. We also know about statin therapy, and consider this in your patient counseling, is that there is a very significant nocebo effect. And a nocebo effect actually comes from Latin. We remember that placebo comes from the Latin I shall please, and a placebo effect is when somebody goes on no treatment, they get a therapeutic response. Well, the nocebo effect comes from the Latin noceo, which means I shall harm. And what does this nocebo effect? It means that patients, their prior expectations before they even start therapy is that they're going to have a side effect. The nocebo effect is that in itself. It's the opposite of a placebo effect, where patients are engineered and preconditioned to expect to experience a side effect to a statin. How do we know that the nocebo effect is prevalent with statin therapy? There's more than one publication out there, but one that was somewhat more recent is called the Samson trial. It's an N of 1 trial. They looked at 60 people who had abandoned their statin therapy in the past, and they had no intention of restarting. Why did they abandon their statin therapy? Well, they had a history of statin symptoms arising within 2 weeks of starting their drug. So these were 60 people that were statin resistant, I guess, or statin defiant, where, oh, I'm not going to take a statin at all. But they still enrolled them in this trial. It was a multi-crossover, 3-arm, double-blind, placebo-controlled trial for 12 months. And what really happened here? For 12 months, patients were given 12 different bottles. 4 of those bottles, and 1 bottle for each month, right? So four of those bottles contained real statin, atorvastatin 20 milligram capsules. The other another 4 months, it contained placebo bottles, which had drugs that looked like there were capsules that looked like atorvastatin 20. It could be atorvastatin 20, but patients had to swallow them every day during that month. And then for 4 months, it was an empty bottle. We call that the nil treatment. Patients opened it up, they knew they were on nothing, and they didn't even have to swallow anything. Each bottle was used for 1 month, and it was random throughout the whole year. Some people got all four of their drug in the first 4 months, and spattering of randomization for the other months or all across the board. But the key here is that on a daily basis, patients had to log their muscle symptoms. Either 0, when they log 0, they had no symptoms, and 100 was their worst imaginable muscle symptoms. Now, if we look at these 60 people, they were about age 66, good split of men to women, mostly white people. But look at the number of statins that patients had tried prior. Most people tried 2 or more statins in this trial, and it had been a while since their last statin therapy, almost 3 years. So these were patients that were apparently challenging. What happened with their muscle symptoms, where the data are on the left? So what's plotted here is the average symptom score out of 0 to 100 for each of the months averaged out. And we see that no treatment, the average score was 8. But that is significantly lower than placebo, which was up to 15.4, which is only marginally lower than what was occurring with statin therapy of 16.3. So what is this telling us? This is telling us that the physical act of taking a drug, which people are told, a placebo for that matter, that they're told there might be a side effect, caused the muscle side effects or was associated with the muscle side effects. If there is no nocebo effect, then the rate of symptom scores should be exactly the same for placebo and no treatment. But placebo was higher than no treatment. This gap, and I will say, it's clear that the statin red bar is higher than the blue bar. It's not statistically higher because there was only 60 people, but it was higher there. The difference, what was the side effects that were associated with the placebo effect, which were not attributed to the drug, is called the nocebo effect, and it was 90% in that difference. Now, I won't say that statins do not have side effects. If you look to the graph to the right, it sort of plots treatment periods where the tablets had to be stopped in percent versus days starting the tablets. And we see that patients on statin therapy did more of them stop therapy because of side effects than those on placebo. So there was a gap there. So I believe there are side effects related to statin therapy, but they're nowhere near what people think that they are. 90% of the reported side effects are from the nocebo effect, but the other 10% are real, as indicated in the Samson trial also. The National Lipid Association has a clinical perspective that's published about how to manage patients who have statin-associated muscle symptoms. Now, this is beyond our protocol to some extent, but this is part of when you start statin therapy, knowing how to manage side effects and how we educate patients is important. They went through the literature and identified that there's many proven strategies on how to address statin-associated muscle symptoms, sometimes using a lower dose of the same statin, switching a statin, using an evidence-based alternative, perhaps even telling patients about naturally derived statins, which is mostly simvastatin and lovastatin. Not that they're the safest statins, but sometimes patients feel, the naturally derived, fungal derived statin is better than synthetic statin, and maybe it's better patient acceptance. Conversely, some people argue that synthetic statins have fewer side effects than the fungally derived ones, probably because of lipophilicity, but it's something that at least is cited in this particular clinical perspective. Some strategies to avoid include using supplementation such as vitamin D preemptively without a good reason does not help. Coenzyme Q10 does not help, and other nutraceuticals as alternatives are not recommended either. In our patient education, it's really important to engage in clinician-patient shared decision-making. This is where, as a pharmacist, if you're initiating statin therapy, you assess ASCVD risk and you share that with your patient. You talk about lifestyle modifications. We should focus in on the net clinical benefits from pharmacotherapy, identifying the cost considerations that patients may have, and really sometimes giving patients a choice. Maybe one statin versus another if they're statin eligible. Is something that empowers them. There's some tools by the Mayo Clinic which help explain 10-year risk of having ASCVD using dots, green dots versus yellow dots, and green dots are the people that will have no heart attack, and yellow dots are people that will have a heart attack. You can get this kind of figure on an individual basis if you put in your patient's individual risk parameters. So these are all important in individualizing the care that we deliver to our patients and giving them some sort of power to engage in their own health care is the whole essence of clinician-patient shared decision-making, and this will hopefully increase the likelihood of adherence with therapy. Getting back to the statewide protocol, the pharmacist also must document, and the pharmacist in this protocol will notify the patient's primary care provider of all record and provide a record of all medications that are prescribed. So you can't just enact this protocol and not share that information with the primary care provider. And if they don't have a primary care provider, what do? The pharmacist still will work with the patient by providing a list of providers and clinics for which they may seek ongoing care. The pharmacist also will follow all documentations which are stated and outlined in Rule 17. And again, I do direct you to this website to get the full protocol and have it download it for yourself and read through it and understand all the rules and regulations. What is part of the referral to a primary care provider? Well, what do you include? Well, you should include, as a pharmacist, if you're using this protocol in an individual patient, the prior history of statin use, with noted any severe intolerances. The pharmacist is encouraged to work with the PCP on identifying options for your patients who are more challenging, who have a history of intolerance, if possible. For your patients that are on therapy, if the patient experiences any adverse effects, such as moderate to severe statin-associated muscle symptoms that don't resolve with stopping statin medication, that's when you should refer to a primary care provider. If the patient has symptoms which appear concerning, such as severe muscle weakness or rhabdomyolysis, which is dark brown urine with severe muscle symptoms, the patient should absolutely be referred to stop the statin, and in this circumstance, probably referred for emergent care. We should also refer to a primary care provider if the patient develops any symptoms that are suggestive of liver disease, like abdominal pain or yellow-colored skin or eyes. That may be a symptom of hepatotoxicity. It's extremely rare. All these are, but if it happens, that's a good instance for where we should refer. If the patient becomes pregnant, you stop the statin. Recommend they stop the statin and follow up with a provider. Also, those are the on therapy sort of bad things that could happen. You should, if you're doing the ongoing measurement of LDL 4 to 12 weeks thereafter, even though the protocol only allows us to initiate statin therapy. If you don't have a CPA or a CDTM, if a patient does have a suboptimal response to maximally tolerated statin therapy, you should recommend to the patient that they refer to their provider for further workup and for further titration. This is not a titration protocol. This is an initiation protocol. So in conclusion, what do we know about this statewide protocol that we have in Colorado? It is for statin therapy, and it allows qualified pharmacists to initiate statin therapy in patients in one of the 4 statin benefit groups. Keeping in mind that for the first statin benefit group, it includes all patients with secondary prevention status, meaning clinical ASCVD. In the second statin benefit group, it includes all patients who have a baseline LDL of 190 or greater if they're at least 20 years of age. In the third statin benefit group, for your diabetes primary prevention patients between the ages of 40 and 75, if they're type 1 or type 2, it includes all those patients if their LDL is less than 190. But for the fourth statin benefit group, your patient must be age 40 to 75 and their 10-year risk score needs to be 20% or higher. If it's less than that, even though guidelines may recommend considering a monointensity statin, that's not included in the scope of this protocol. Also, we should know as pharmacists that statins really and truly are safe and effective first-line therapy. They're recommended in the 2018 guidelines, and it's because they're proven to reduce cardiovascular event risk in patients in one of the 4 statin benefit groups. We do have a lot of patients that may have statin-associated muscle side effects or other side effects, and they can be managed. There are some severe side effects, but they're extremely rare. Possible, but extremely rare. Clinicians, including pharmacists, should discuss the benefits and risks of statin therapy with our patients prior to starting the statin therapy. We want to avoid that nocebo effect. Patients often hear the negative side of statin therapy, but it should be balanced with the positive side of statin therapy. The bottom line is these drugs are underutilized, and the ability for them to reduce cardiovascular events is huge. It's just that we are hindered by the perception of statin therapy in the lay community, And we as healthcare professionals need to improve that to avoid the nocebo effect or statin defiance, which is your patient just refusing statin therapy because of disinformation or misinformation about the benefits and risks. Also, clinicians should include referral for ongoing care and identification of recommended LDL reductions according to our national standards, which are the LDL thresholds included in our ACC expert consensus decision pathway. Thank you for listening to this presentation. I hope you feel empowered to use the statewide protocol. Please read it for yourself. This gives you some training and information, but I think a little bit of experience and reading through the protocol more than once is the key to success in fully and successfully implementing this protocol, which is intended to improve the health of Coloradans.